Hello and welcome to Fertility Fact or Fiction, our show on the web where we review all things fertility and discuss all the newest topics and try and dispel the myths and make your fertility journey cheaper and more successful at the same time. Today I am joined by my amazing colleague, Dr. Jennifer Strong, our naturopathic doctor, who is going to be talking about her Fertility Foodie program and their book club. So we're very happy to have you here today. So thanks for joining us, Jen. And then we're going to jump into a brief article, which I think is really interesting for a lot of people. And from there, we'll answer your questions live. Tarek is with us, but in spirit only, because he couldn't be here live. So you will hear him through the digital system, but not through the normal here in person version. So Jen, take it away.
All right. So we're going to start book club. I've been here for 3 years now, actually, to the month. And when I first started here, I had a lot of ideas on how to make this more engaging. And one of the ideas was book club. Once we got settled, the pandemic hit, and then we kind of sat on it. So we're going to do a virtual book club. The idea is to provide a lot of resources to those who are interested about things that can help with fertility in terms of food choices, the psychological piece, the emotional piece, and it'll be open to everyone who's a part of it to add the content as well. So it's up on the website. If you go to drvictory.com, there's a resources tab. And then just hover over the resources tab. Don't click it. It doesn't work if you click it, but hover over it and choose it. And then you can log in and find, there's probably about 60 books in there right now.
Oh, wow.
And then you're always welcome to add what you've found helpful too. So we're going to do our first virtual book club at the end of the month. So February 28th at 7, we're going to do the book called Daring Greatly. So this is by Brene Brown. Has her PhD. She's she calls herself a storyteller researcher, and she's been studying vulnerability for probably 15 years or so. So this book is great. Daring Greatly: How the Courage to be Vulnerable Transforms the Way We Live, Love, Parent, and Lead. So the goal is to go through the first couple chapters in book club. Talks a lot about vulnerability, and it's something we can apply to all different areas of our life. We're going to try to keep it light and fun. And Darcy will be with us then too. Darcy's the social worker that's present at the fertility clinic here. So she'll have lots of good things to add to it. And
I abandoned Darcy once on the show, and she had to do the show.
I remember that. Yeah.
That was quite the experience for her, but trial by fire, and she did great. So it worked out well. Yep.
Yeah, she's a great resource. So between the two of us, we'll have lots of info to share, and then anyone who wants to join is welcome to share then too.
So have you read this particular book already?
Yeah. So I read this like 5 years ago. I was kind of in a different place in life, but then reading it again now, I think it's pretty applicable.
Yeah.
It's a good one.
Awesome. And our patients are extremely vulnerable because of everything that they're going through, of course. And so this is a great opportunity to share that kind of information and how to deal with that as they go through it. Jen is one of our amazing resources that we turn our patients to when they are struggling, because she's incredible at dealing with stress and helping people navigate through parts of that with naturopathic approaches, which is wonderful. And I think a lot of patients really love that, because the medical portion of this is taxing enough, and then there's the emotional and the psychological, and people love it when there's just like a more holistic, natural approach to things. So thank you for everything you do. That's been awesome. And our patients all love you. I love you. You're amazing. So this is great. So the 28th?
Yeah, so Monday, February 28th, 7 o'clock.
Okay.
Yeah, it's on the website. If you have trouble on the website, just reach out through Facebook.
So are we going to do that here?
So it's Zoom, so we can do it from anywhere.
Oh, so do
you want to be in it too?
I'll probably
Are you volunteering
try and join. Yeah.
Okay.
Tarek, you and I have some reading to do, buddy.
Yep. Here it is.
All right. Well, that's amazing. Thank you for joining us. Anything
Thank you.
else you have to share?
Oh, you mentioned Fertility Foodie. So
Yeah.
that is 99% ready.
Okay.
Right, Tarak? So it'll be up on the website very soon. So Fertility Foodie is pretty much, so I've been practicing for 15 years, and over the years, I find I have a lot of good info to share and kind of repeat it quite a few times. So we put it all in one big document. It's the research behind the nutrition of what we recommend in terms of supporting fertility with food.
And Jen and I are talking about taking it one step further and cooking together some of the meals that people think are fertility appropriate. And you see on a lot of the nutritionists' guides and websites and Instagram accounts, and then tasting it and seeing how it is. So that might be a fun thing to try. We can put the videos on YouTube. So yeah, you'll see us working on that in the near future. So thank you so much.
Okay, thank you.
We'll look forward to seeing how that goes, and we will join you because we can probably roll right off of that into our show. So
yeah.
So T, it's going to be a long night on the 28th. So bring your appetite.
I'm here. I'm ready.
There you go. Yeah, bring your appetite and bring your book and start reading Daring Greatly. And this is available through Amazon or any bookstore.
Yeah, and she also has a podcast on Spotify.
Oh, okay.
And a ton of TED Talks. So if you're not into reading, you can listen on Audible or ebook or catch the talks.
Fantastic. Thanks, Jen.
Okay.
Yeah, always good to see you. Thanks for joining us. Have a great day. See ya. Okay, I'm going to rotate this over a little bit and slide this chair out of view. And whoops, it's still in view. And we're back at it with the show. So thank you so much for everything and for having Jen here. It's always an amazing opportunity. Jen is like the best resource because she is brilliant. She's really smart. Patients love her. So we really, really are very fortunate to have Jen here. And thank you for joining us tonight, Jen. Okay, so tonight's topic. T, if you want to pop up the image of the talk. This just came up in Human Reproduction, which is one of the premier fertility journals. And it's called The Association Between Miscarriage and Fecundability, the Norwegian Mother, Father, and Child Cohort Study. So everybody knows what a miscarriage is. It's a loss of a pregnancy prior to 22 weeks. But a fecundability, most people will have no idea what that means. So that's your chance of conceiving in any given month. So, most people would say it's 15, 20% per month. Some people say a little bit more. So, that's the chance. So the question these guys asked is there a relationship between a previous history of miscarriage and your chances of having fertility problems? And does the time to conceive then predict your chances of a miscarriage? So basically, they wanted to know both ways. Does a miscarriage predict fertility problems, and do fertility problems predict miscarriage? So the great thing about the Scandinavian countries is that they have socialized healthcare systems with massive, massive data collection that has gone on for decades and decades. Very, very sophisticated. And so when they want to do these epidemiological studies, they can just kind of take the data, look at it, put it all together in a database, and then say, we want to ask this question. What does this question look like? And, what kind of data can we get, and what kind of information can we get? So in order to do that, these guys basically went ahead and looked through their data set to see how many women had had a miscarriage over a certain time period. And then how long did it take them to get pregnant? And did they then, from the people that did get pregnant, how long from the time that they got pregnant was it to get pregnant? And then if it took them a long time, were they at a higher risk of then having a miscarriage once they got pregnant? So kind of an interesting study, a neat way to kind of look at things, a little bit different from what we've seen before. Studies prior to this had looked at whether or not a previous history of miscarriage predicted infertility. And then there were studies that looked at whether your infertility predicted a miscarriage, but no one had done both on the same thing. So if you want to pull up figure 1, we'll show you basically their setup. I don't know if you can kind of blow that up full screen or not, T, but we'll have a look at that. So the MOBA pregnancies are all the pregnancies in this specific database that they used. And in total, over the time period, there was 112,694. And it went from 2008, I think, all the way out to 2014. About 10,500 or so were missing info, so they eliminated those. 102,000 finished the first questionnaire. A bunch had either unplanned pregnancies or pregnancies with infertility treatment. They didn't want those patients, so these were only people that were natural. And about 1,900 were missing data on time to pregnancy, which is what that TTP stands for. So they had complete info on 80,000. 27,000 had no prior pregnancies. And then before 2008, there were 67,000 that had had pregnancies. For those that had had at least one prior pregnancy, which they really wanted to focus on, there was 53,000. And then a few more that had these 2008, 2009 pregnancies. So when you scroll down a little bit longer, a little bit further there, T, you get down to the bottom, and in total they had 2 study populations. Study population number 1, 48,537, so still a huge number of people. And study population number 2, where they looked at time to pregnancy and miscarriage risk, was just under 8,000 people. Again, that's a huge number of people. So what did they find? What they were looking for was essentially, initially, what's that relationship between a previous miscarriage and your chance of having infertility. So if you go to table 2, I'll show you that. And they have a whole bunch of demographic data, but I won't bore you to tears with that. So Tarek's going to pull up table number 2, and we'll go over that data. So looking at table number 2, which is on the screen now, you can see that if you had never had a miscarriage before, that was 35,000 of the 48,000 people. They had a total number of 125,712 cycles that could potentially lead to conception. 33,000 of those were able to get pregnant within 6 months. And out of those, they were used as the reference category. For the patients that had at least one previous miscarriage, you're now looking at 10,400 women, 41,000 cycles. Again, 9,671 were able to get pregnant again. So that's great because that's a substantial portion of the population. But you can see that the adjusted fecundability ratio is 0.83, which means in those patients that had had one previous miscarriage, there's a 17% decrease in their chance of getting pregnant compared to the ones that have never had a miscarriage before. That's important because that's a huge decrease in success. If you're going from, let's say, an average of 5 to 10% per month down to somewhere between 4 to 8%, that's a big difference for people. So important numbers to have. The more interesting thing is that this is dose dependent. So if you've had 2 previous miscarriages, your chance of getting pregnant. So this isn't your chance of having another miscarriage. This is your chance of just getting pregnant within 6 months, decreased by 21%. So from 17, you're going up to 21. And if you had 3 or more, your chance went from, I think something funky happened there, Tarek. So your chance went from from the 21% up to 26%, which is how you get that 0.74. So a very significant increase in your risk of infertility or failing to conceive if you have had more and more miscarriages. So reducing the number of miscarriages is critical. And this was adjusted data where they controlled for things like your age and your body mass index and your smoking status and all of these important factors. So very, very critical data. So they then went, and we're going to go to table 4 now. and they looked at, that's table 2. Yeah, keep scrolling down to table 4. Yeah, so they then looked at what's the impact of the time to pregnancy on your risk of having a miscarriage in a subsequent pregnancy. So what they did with this was they said, if it takes you longer, meaning you are infertile, it's taking you longer to get pregnant, does that predict your chance of having a miscarriage? So their reference category was it took you less than 3 months to get pregnant. So about half of their population fell into that category. About 519 of them had miscarriages. And so they're basically looking at that as the reference. So when you look at the group that took 3 to 6 months to get pregnant, so a little bit longer, double what the reference group is, there was a non-statistically significant increase in the risk. So if you look at the unadjusted risk, it's 1.19, which means roughly a 20% increase in your risk of miscarriage in your subsequent pregnancy. Excuse me, but when they adjusted it for the miscarriage history, or not for the miscarriage history, that dropped out because your confidence interval crosses 1. So 3 to 6 months, you're still safe. When you go for 7 to 12 months, exact same thing, non-significant increase across the board. But if it took you more than 12 months to get pregnant, there was a very highly statistically significant significant increase of somewhere between 41 to 53%, depending on what they adjusted for, in your risk of having a miscarriage. So in other words, if it's taking you a really long time to get pregnant, your risk of having a miscarriage in that subsequent pregnancy is higher, meaning miscarriage can predict infertility, which they showed in table 2 that we just shared with you, but infertility can also predict miscarriage. So these two go hand in hand. And interestingly, the trend in all of these going from, for example, if you look at the far right there, from 1.15 to 1.17 to 1.41, when that's adjusting for miscarriage history, this trend of increasing rate was significant. So although those individual categories for 3 to 6 months and 7 to 11 months were not significant, the overall pattern is, which means if they had larger numbers, we would probably find significance. So for those of you who have unfortunately suffered a miscarriage, this is critical data because it does tell you you do need to be cautious in that it could predict a more significant compromise or difficulty getting pregnant. And for those of you that are struggling to get pregnant and it's taking you a long time, you also have to brace yourselves for the possibility that you may actually experience a miscarriage when you are trying. So not the most, for sure, happy data that we experience in the stuff that we do, but important because patients need to know this when they're going into it so that they're prepared for the outcome and aware of, what could happen to them when they're going through these treatments and when they're going through, the fertility journey. So I hope you guys get some information from that that's useful. We're going to flip back to the question and answer part of the show, but is it true or false, a fact or fiction that your infertility predicts miscarriage and that miscarriage can predict infertility? It's actually true. Miscarriage can predict infertility and infertility can predict miscarriages to some extent. So, make sure that you have people that are watching every single aspect of your care and make sure you're doing everything you can to minimize your risks of miscarriage, because that is something that is potentially modifiable. Healthy diet, healthy weight, avoiding, substance exposures like smoking, drinking, drug use, staying on all your vitamins, using your supplements. A lot of this stuff can have a positive benefit and a bearing on how things are going. Okay, so we will take your questions live now. I tried to get that done quickly so we had lots of time for questions. T, do you want to start reading from the bottom, or do you want me to?
I'll go from the Instagram post first.
You're going from Instagram. Okay, perfect. Fire away.
How long after excision do you recommend waiting to see if you can conceive before IVF?
How long after excision?
Yeah.
So I guess they mean after endometriosis surgery. you can do it basically the next month. The longer you wait, the more the chance that the endo will come back. So you don't really want to wait too long. You want this to happen sooner rather than later.
God bless you for not closing your clinic during Omicron. Wish others followed suit. Well, this one post.
Yeah, and it's coming around now. I think we're coming out of the pandemic. So thank God it's almost over, guys. Yay!
What percent of frozen embryos don't survive thawing process? Have 3 waiting for LHSC to open.
Oh, well, it depends on what center you're using. I can't speak for LHSC. I can speak for our program. We've had one in the history of our program that hasn't survived. So not very often. So probably like less than half of 1% of embryos will not survive in our program. Most programs have very high survival rates for embryos, but we never know.
I think I have an umbilical hernia. Anything I can do?
Well, if you're pregnant, there's not a whole lot you can do. Just watch your weight. They're pretty uncomfortable. If you are not pregnant, surgery is the answer to that. So see a general surgeon. They make a tiny little like 2-centimeter cut and fix the hernia, and it should go away after that. If they get very large, especially in people who have liver disease, it's actually quite dangerous. So make sure that you're getting evaluated and make sure you don't have any comorbidities.
We have 17 blastocysts ranging from 2AA, 2AB to 3AA, 3AB.
Okay.
No 4 or 5. Causes?
I guess it would depend on when they froze them for you. So if they froze them really early, they'd be smaller. If especially if they were all day 5. If you had just waited one day, you would have had day 6s. The other possibility is that there's some kind of compromise, but if you have 17 blastocysts, I'm sure they just froze them early. That's someone that was trying to get out of the lab quickly and wanted to freeze them early. But there's nothing wrong with those embryos. Those are very high quality embryos. And if you thaw them and wait, they'll start to expand. So there's actually nothing wrong with that. I wouldn't worry about that. Those are strong results.
Dual stim protocol for poor responders.
So we have a video on DuoStim, and there are more and more studies now on DuoStim, all demonstrating that it is very, very beneficial. So we use DuoStim for our poor responders all the time with fantastic results. I actually just had someone come to us from the Virgin Islands, of all places, and she had one cycle where she did the best she had ever done, the follicular phase, and we just yesterday did her luteal phase, and she did even better than she'd done before. So yeah, it's very manageable to get great results with DuoStim, and we've seen nothing but good results with it here. I can't think of one cycle where it didn't work well.
What tests should I do before my last embryo FET? 1 miscarriage, 2 failed FETs.
Oh, I get asked that all the time. So, I would go beyond just testing. Those are frequently cases where if your RE is not already talking to you about options and alternatives and tests that can be done and things that you can explore, I would argue that you really need to kind of have a discussion with someone that can help you and can answer that stuff for you. So I would say reach out to me or to anyone out there who's willing to listen and go through your history. There are several of us out there, and then go through things in detail. In general, vitamin levels should be checked. Your social habits and your partner's social habits should be checked. Your general health, your body mass index. We use Fertilisys for immune testing, for the infectious testing. You may want to do hysteroscopy, laparoscopy to rule out endo. That would, in my opinion, be mandatory with your history. So there's a lot of things you need to consider, but that would definitely be something I would be focused on.
What is the effect of COVID on the baby in early pregnancy? Any future health risks for the baby?
So in early pregnancy, COVID has no impact on the baby unless I shouldn't say that. If you are unvaccinated, COVID can have a tremendous impact because it increases risks of high blood pressure, preeclampsia, stillbirth, miscarriage, preterm labor, preterm delivery, premature rupture of membranes. Pretty much every risk of pregnancy we can imagine is increased in patients who have COVID and are not vaccinated. However, if you're vaccinated, there are virtually no risks to the pregnancy at all, unless you get a very high fever. Fever can cause miscarriages, but most people that are vaccinated are not getting high fevers. So vaccination is the key to protect you from the impact of COVID. If you are not vaccinated and you get COVID, there are huge risks, and maternal risks are even more important than the fetal risk. It's a 22.3-fold increased risk of maternal death if you get one of the original COVID variants and you are not vaccinated and you're pregnant. So you need to all take that very, very seriously.
What's your opinion on the Zymo, please?
Yeah, we use Zymo all the time. For patients with high DNA fragmentation, we use it. My lab is not a huge fan of using Zymo for patients who have poor motility because you get so few sperm on the other end of it. But we use it all the time. The Zymo costs us, I think, $86 and is a lot more work, and we only charge an extra $100 to do it. So yeah, we use it, and we think it's a very reasonable approach to things. I think other places are charging a lot more, which probably makes it less usable, but we really don't charge that much to do it.
Is hives considered an immune issue, and can it cause implantation failure when flare up?
Hives, H-I-V-E-S-E? H-I-V-E-S?
Yes.
Yeah, absolutely. I mean, if you're having hives, your immune system is overactivated. And if you have a flare at the time of a transfer, you're reacting to something which is going to overactivate your immune system, which is going to compromise your success. So absolutely, it's a major issue. That's something that would for sure need to be dealt with. There's no question there at all.
Is pelvic pain when running a cause for concern? Very painful, no endo, confirmed by surgery.
So having pelvic pain, but there's no endo, is that a cause for concern? It can be. I mean, it depends on the source. If you have adenomyosis instead of endo, that's still a potential source of infertility or compromise. If you have primary dysmenorrhea, you would only get pain with your periods. You wouldn't have pelvic pain all the time. So that one is less important. But I would want to know why you're having the pain. So is there an infection in your uterus or your pelvis? That's something you can look at and needs to be explored because that would have an impact. Is it related to adenomyosis? That can be looked at. Otherwise, if it's unexplained, we wouldn't know. But, you know, there are ways to explore it for sure.
Dear doctor, is there higher success rates with natural cycle versus with meds for frozen transfer on uterus? Is it necessary to do surgery before transfer, and can I transfer with the polyp?
Oh, okay. Let me go backwards through those. So if you have a polyp, you absolutely need to get it removed because it's a huge decrease in success and it's a huge increase in miscarriage risk. So do not try an embryo transfer with a polyp. You must get surgery first. If you are asking about natural versus stimulated or hormone replaced, there are many studies on this topic, and they basically all say the same thing, which is there is no difference. So there are people that believe natural is better. There are people that believe stimulated is better. I kind of believe in a middle road. So we take a very low dose stimulated with some natural elements to it. And that seems to work out fabulously for us. So that's what we're doing. But everybody's different, and there are lots of different successes. If you look at our video from last week where we reviewed the top 13 programs in the US and what they had in common, a really fascinating study. They basically said it was sort of half-half. Some of them used natural, some of them used stimulated. It didn't make a difference. They were all getting top rates that were 15 to 20% higher than the average. So, you know, that's not going to make you or break you. Both are acceptable approaches to things. It's very weird kind of looking at myself because I'm watching the software that we use. So I'm kind of looking at me, but I have to look above me, or else it looks like I'm looking.
Don't look at you. Don't look at you. Don't worry. You
I
look
know.
great.
This is a very strange episode. All right, you got to float some Twilight Zone through here at the moment.
Yeah, no problem. Fertility tested positive for bacteria. Working on antibiotics you prescribed me. Can bacteria be a root cause to my high TPO antibodies? My TSH is normal.
Wow. That's a fantastic question. That's some real scientific thinking. I have no idea. No one has ever looked at that. I have no idea. I'd have to look that up. I'll look that up on the way. What's the next question? Let me see if I can find something.
Are you offering IV vitamin therapy yet?
Very shortly, actually. I think Jen, who was just on the show with us at the beginning, will be doing that. Jen, if you're watching, can you tell us if you'll be doing IV vitamin therapy and when? It won't be me that's doing it. It's Jen, because there is data showing that the intrafollicular concentration of vitamins actually has a impact on your success rates. In fact, it was predictive of live birth. So it wasn't just like a minor thing. It was a huge thing. So let me just see if there's anything on bacteria and thyroid antibodies. Let's see if there's anything here. Nothing that's jumping out. There's something about herpes viruses, but not on the first page. So no, nothing that I see immediately. But that's an interesting question that reader or watcher asked. So I'll look into that a little bit more. You may have found something interesting to look at. Okay, next one. I'm kind of out of focus, aren't I?
Yeah, there you go.
Is it back?
No, not yet.
Okay, go ahead.
Okay.
I'll see if I
Hey, Dr.
can.
V,
Yeah.
thanks for your live session. My partner's DNA frag is at borderline 16.2.
Okay.
Existing reason for IUI failure. What would you recommend to lower his DNA frag other than supplements?
Ejaculate every day or every other day. Keep the testicles cool. No smoking, no drinking, no drug use. Lots and lots of supplements and vitamins. But 16.2 is pretty close to normal, so that's definitely not affecting things. I gotta refocus this somehow. I'm not sure how to do that. Let's see if that works. A little better, kind of, vaguely.
I'll turn it off. I'll turn it on and turn it back off for you real quick.
I wonder if I might have to do it from here. Let me try doing it from here. Hang on a second. We'll switch it to this camera, and then we'll switch it back to that camera.
There you go.
Better?
That works. Yeah.
All right. There you go. Yeah, there we go. Perfect. Yeah. Sorry about that, folks.
Another question. What will be the approximate cost of a non-funded IVF at your clinic?
Yeah, it depends on what you're doing. So if you're looking at doing just a basic cycle, like one egg, we start as low as around 6,000. If you're looking at doing a live baby guarantee, it's substantially more. So your entry level's around 6. It goes up based on what you want. So a standard IVF cycle is just over 10, and that's including everything but your meds. A duostim is about 17. A live baby guarantee is, I think, around 22 or 23. So we generally are amongst the cheapest in the country, and we're really proud of that. So answering an Instagram question.
Yeah, fertility books are fertility fuel. I need to do more reading myself and would love a top 10 list.
Oh, awesome. I will come up with a top 10 list. We could probably do, I guess we could do a book review on this. This is unlimited. You and I are going to be working around the clock. Yeah, you know what? I'll come up with a top 10 list. I don't know about top 10. I don't know that there are that many great books out there for fertility, but I can come up with a top 5 for sure. So I'll go through that with you. And go from there. I mean, probably one of the best is It Starts with the Egg. So that's definitely a great book. But yeah, maybe between Jen and I, and we'll come up with some books that are useful. Yeah.
I can write a book if you want, Ryan.
You can write. Absolutely. I think that would be awesome. I would be happily willing to read that book.
Yeah.
I'll even edit for you.
That's what I'll need you for sure.
There you go.
Hey, Dr. V, I'm wondering if there's a limit on how many funded IUIs you can do in a year. We had our second one yesterday, and we're thinking of doing 3 to 4 before moving to IVF.
So at our clinic, we allow 3 per year unless they change our funding, which we are praying that they do. But we allow 3. Clinics that have a lot of funding, they don't restrict how many you can do. So it depends on where you go.
Hi, Dr. Victory and Tarek.
And Tarek. Tarek, you're back in action again, man. I got to adjust this camera. There we go. Yep.
Which progesterone and oil is best tolerated or least painful? And sesame oil, olive oil, ethyl oil, or cottonwood seed?
So that's a really good question. And the simple answer is that everybody reacts differently. So there is no simple answer to that. Some people are better on one, some people are better on another. Most of it is made in the sesame oil, I think. But we formulated it in different ones. I don't think there is any data that says that universally one is easier than the other. I think we just tried it in one patient in olive oil because she couldn't tolerate it in anything else. So we'll see how that goes too.
So relating to the study that we just looked at, did the study differentiate between early miscarriage and later miscarriage? Example, 8-week miscarriage versus 18 weeks?
No, it was actually all miscarriages up to 22 weeks. There's a question that just popped up that I see related to my answer about our prices. So let me take that super quick. So someone asked what a live baby guarantee is. Now somebody else is wondering. So it's literally what it says it is. We guarantee you a live baby or you get most of your money back. So for people that qualify, we can allow some people to pay a little more as a premium. But then if they don't walk away with a baby in their arms, we give them back most of what they paid us, basically the vast majority of it. So for those patients that want that extra security and they qualify, they like doing that. And that's something we've tried on those patients. So a lot of people love that because it's risk-free for them. And you even get up to 2 cycles to succeed. So it's a good way to go for people that want that extra comfort and want me to put our money where our mouth is, essentially, and live up to what we claim. So we do. Yeah. Okay, sorry, didn't mean to throw you off track there.
That's all right, I found it. They're saying T, your audio is sounding a bit far away, like you're in a black hole.
He is in a black hole. We tried it the other way, but because he's not here in studio with us, this is the best we can get. Tarek is currently on my cell phone, so you're hearing him on this guy. Yeah, so that's as good as it gets.
Right, but the people love me. They notice.
They do. Everybody loves you, man. Of course they do. How can anyone not love you?
There you go. Can fibroids outside the uterus cause preterm labor?
Yes, if it's big enough. There are associations between pregnancy complications and fibroids, and preterm labor is one of them. Not if you have small fibroids, but if they're huge or they degenerate during the pregnancy, they can definitely cause complications.
Doc, my girlfriend and I are hoping to work with you soon. And then right underneath, I believe the girl says, yeah, what he said.
Well, that's awesome. I'm looking forward to taking care of you. So we'll get your history done and then figure out what tests you need and get you guys started on the pathway to success. Not a problem. That's what we are all about.
Dr. V and T. How successful has your clinic have your low mosaic or high mosaic transfers been over 40?
Over 40. Okay, so we don't transfer high mosaics because it's not recommended to do so. Low mosaics, we have not had to transfer too many. If you look at so certainly not enough for me to make claims about success rates. But I will tell you, and that's probably a reflection of the fact that we normally get a lot of perfectly healthy embryos without them being mosaic. But I will tell you that the literature now supports the fact that a low-level mosaic, especially if it's segmental and not whole chromosome mosaic, basically has the same chances as a euploid embryo. It's 50-50. So if you have a low-level mosaic, you should expect a 50-50 chance of an implantation.
Okay, back to Facebook. Also discussed before, if you have endo and your doctor is prescribing high doses of estrogen, that'll affect your endo. What would you do to help improve lining thickness?
Letrozole, PRP, aspirin, Viagra. There are lots of non-estrogen ways to thicken your lining without having to worry about overstimulating your endo. So we do that every day. And I think that's a big part of why our success rates are so high. So for sure, it's something very reasonable to consider. All of those things have been shown to be beneficial. Vitamin D, vitamin E have also shown promise. Pentoxifylline can work. GM-CSF can work. So, I mean, there's a whole laundry list of available things you can do to improve your chances and thicken the lining at the same time without affecting the endo at all.
If this question has been asked before, I apologize. Myself, along with many other women, have been experiencing mid-cycle bleeding after receiving the Pfizer vaccine. My family doctor says it's been shown to thicken the lining of the uterus. Could this have any positive effects on fertility?
So there is data now looking at the chance of or the impact of COVID vaccination on fertility, both on your chance of getting pregnant and on your chance of getting pregnant if you're doing assisted reproduction, so IUI, IVF, whatever. It has zero impact. It has absolutely no impact. There is no impact of being vaccinated on your chances of getting pregnant with or without fertility therapy. So don't worry about that. It doesn't make it helpful and it doesn't harm you. At most, you may need a delay of 1 or 2 months because of cycle delay, but that's it, nothing else.
Hi, Dr. Victory. I would like to ask about Humira. I'm getting 2 shots 3 days after FET just because I had to wait for the Quantiferon Gold TB.
Whoa. I don't even know what Quantiferon Gold TB is. So Humira has data on its efficacy for fertility in one study where they used it with IVIG, and they took patients that had had 6 previous failed FETs, and they got an 80% success rate in getting those patients pregnant when they put them on the combination of Humira and IVIG. I have actually used it before. I don't believe a word of that study because it just makes absolutely no sense. There's no way you went from getting 6 failed embryo transfers to all of a sudden a 60% pregnancy rate. It's impossible. And secondly, when we did it, it literally didn't work. So, and it was someone that actually needed Humira, like they had arthritis, juvenile arthritis, and it still didn't work. So the jury's definitely out. I haven't re-looked at Humira use because we have other things that we use now, which are way less expensive than doing Humira and a lot more wallet and patient friendly. So that's what we stick with.
Hi, Dr. Victory. What is the difference between Orilissa versus Lupron to treat endometriosis? Why do you treat endo with Lupron with Letrozole?
Endo with Lupron with Letrozole because, and there's a video on our YouTube channel for this, we've reviewed it on the show. In unexplained failures, which they attributed to endometriosis, 3 months of Lupron and Letrozole normalized your cycle, so it gave you a much better chance. So that's why we do Lupron and Letrozole. Is there a difference between Orilissa and Lupron? Not according to the people that make Orilissa. They've done a head-to-head comparison for endo in terms of pain, and it did not show a difference. But no one's looked at that in terms of fertility in a head-to-head comparison. So we're still going to stick with Lupron until there's data to confirm that Orilissa has the same impact. Having said that, it is much easier to tolerate with less side effects than Lupron is. So if you're worried about the side effects of the Lupron, Orilissa definitely has less.
Hello, Dr. Petrian Tarek. My doctor had me get some labs done. It always makes me happy.
I know, it's always,
every single time.
even when you're not with me, I can tell how excited you are.
Yeah, I'll do it again one more time. Hello, Dr. Petrian Tarek. My doctor had me get some labs done. DHEAS 238, what is it, nanograms for DIL?
Yeah, per deal. Yeah.
TSH third gen 4.280
Okay.
ULU over milliliters, and CA 125 30.1 nanograms per mil. I'll share it with you as well.
Is there a question?
The following post, I believe, is the question. Yeah. Put me on dexamethasone 0.5 milligrams and we'll perform laparoscopic surgery because of the results of the CA-125 indicate endometriosis. What is your opinion? Also raise my synthroidosis, hypothyroidism because of Hashimoto's.
Okay, so your synthroid level needs to go up. The dex is questionable based on that DHEAS level. I would want more testing, including a suppression test. Doing laparoscopy based on a CA-125 level of 30 is insane. That is not a justification to do surgery. CA-125 of 30 is normal. Less than 35 is normal. So you don't do laparoscopic surgery based on blood tests. You do laparoscopic surgery based on your history, and that history has to include either pregnancy complication, not pregnancy, like fertility complications or painful periods, painful intercourse, or just pelvic pain. No one should be operated on for endo based on their CA-125 level, unless it's really elevated, but certainly not 30. I mean, that's absurd. I don't know who's doing that for you. That's ridiculous. Yeah. Now, if they're doing it based on their clinical suspicion and you happen to have that random CA-125 of 30, that's a different story. But if they're doing it based on your CA-125 level, you need a new doctor. That's absurd. Just to put it into context, I don't know of anyone that checks CA-125 levels to detect endo. It's useless as a predictive tool for that. And that's been proven over and over and over again. So don't do that. I can read this one. By the way, I'm soon to be through. Oh, it's the same patient?
Same one from Puerto Rico.
Okay. Also had an HSG and found that I have a polyp and scar tissue. Also something he wants to take care of. Okay. So hi from Puerto Rico. And thank you for watching. That's amazing. We didn't know we've had anyone from Puerto Rico. So if you need polyp surgery, that's hysteroscopy, which can be done in the office. And if you have scar tissue in your uterus, that definitely needs to be dealt with. It's not unreasonable to have laparoscopy if they're putting you to sleep, if your fertility history indicates that there's a problem. So I need more info about you. I'd love to chat with you, actually. But bottom line is, don't get surgery based on a number. Get surgery based on your history and your clinical findings.
Also, have you discussed before, if you have endo and your doctor is prescribing high doses of estrogen, that it'll affect your endo? What would you do to help improve the lining thickness?
Well, we did that one.
Yeah, we did that one.
Yeah.
Yeah. Okay. Can you explain the matrix testing and how it can assist with FET in those who struggle with lining issues?
So matrix is an ultrasound scoring technology. So basically we take pictures of your lining after you've been on progesterone for a couple of days, and we send it to Matrix, which is the name of the company. They analyze the ultrasound images and give it a score. So if you're less than 5, don't quote me on this. If you're less than 5, forget it. If you're 5 to 7, then you're kind of iffy and they don't recommend it. And if you're 7 and above, it's considered reasonable. So we've incorporated it for free right now into all of our cycles just to see if it helps us. And we're deciding if it will work or not work. So the jury's out. I don't know yet, but I'm going to test it and see. I don't feel that it's reasonable to charge patients for it, for what we're doing, until we know that it works. So we're eating the cost of it to help you guys out. And if it works, then we'll incorporate it and raise our prices or adjust it or whatever. And if it doesn't work, then no harm done to anyone and we can let it go without any worries. Yeah.
Hi, Dr. V. I have a very heavy cycle and wanted to rule out endometriosis as we are planning on having kids soon.
Okay.
My MD said my blood work looks normal. As for the ultrasound, she said I have fibroids and a polyp. Okay. Should one be concerned? Also, I reside in Chatham. My MD told me to look for a gynecologist. Do you have any recommendations? Thank you in advance.
Yeah, so I do have a recommendation. Dr. Charles Ham, he's excellent. He's really good, knows lots about fertility, and he's an amazing surgeon. So you can find him. And then in terms of should you be worried, I don't know about worried. It depends on how big the fibroids are, where they are, how close they are to the inside of the uterus. Location matters. And then for the polyp, it needs to come out. So that's an easy fix, but that's a 5-second surgery. So yeah, I mean, I would check all of that out. Endo is a different story. So if you have endometriosis, it can play a very negative role in your chances of success. And that does need to be addressed if it's something that is present. It doesn't affect it for everybody, but in a lot of women who have endometriosis, their fertility is compromised.
Can you manipulate your hormones and sperm parameters in a way to be more likely to have a baby boy from your wife?
No. So you definitely cannot manipulate your hormones, and you absolutely cannot manipulate your sperm parameters. This is a favorite topic of mine. It has been tried every which way possible, and there is absolutely no method ever proven to have any benefit whatsoever other than make embryos and then have them genetically tested to see if they're a boy or a girl, and then obviously put it in whatever sex you want. And keep in mind that that is a federal offense in Canada, so no one will do it unless you have a genetic condition which precludes having a baby of one sex or another.
What supplements and vitamins do you recommend for both parties to take with fertility?
Men, a good fertility vitamin, preferably one rich in zinc and coenzyme Q10, L-arginine, L-carnitine, C, D, and E, all the big antioxidants. So guys, just be on a multivitamin for sperm. Examples, and I'm not promoting these in any way, just examples. Fertile Pro or Pro Fertile, both great products, and that's most of what we use. In terms of women, oh boy, so a very good prenatal. So NFH SAP is really great. The Pregvite Folic 5 is really great. There's a lot, Materna, Centrum, they're all pretty reasonable. We actually have a Fact or Fiction with the amazing Jen Strong, who started this show with us today, looking at vitamins called The Good, the Bad, and the Prenatal, right? So you guys can check that out and see that video. That actually has several thousand views on it. So feel free to see that. And when you do, click the subscribe button. So then the other supplements for women, coenzyme Q10, vitamin D for sure, iron, omega-3 fish oils. And then depending on your diagnosis, there are other supplements which can be important, including inositol, NAC, curcumin. We do recommend melatonin for people that are doing embryo transfers. So there are several other supplements to be on. It's like
My
a Jen
doctor
Strong
is worried
question.
that letrozole will increase my risk of ectopic. Is that a thing?
No. Where do people come up with this stuff from? No, there's no risk of ectopic with letrozole. In fact, there's very, very interesting new data which shows that you might actually be able to use letrozole to treat ectopic pregnancies. So no, you don't need to worry about your risk of ectopic with letrozole.
Do you have many patients from the US? What is treatment cost?
We have lots of patients from the US. Our treatment cost is way less than anywhere in the US. So I can tell you that really easily. It's generally speaking around 10 or 11,000, like 12,000 Canadian, but it depends on what package you want. We have different packages. And that kind of includes everything: your IVF, your monitoring, your freezing, making embryos, ICSI, and keeping them for a year, and your first embryo transfer. So reach out to us, do a consult. We will send you a price list. You can go through everything on the price list.
Would doing 1 month of Lupron and letrozole still be beneficial for someone who has endo in prep for FET?
No, you really need 2 or 3 months of it for it to have enough of an impact to make a difference. So 1 month is not enough.
If I had a CA 125 level of 54, should I be concerned? My clinic told me not to be.
54 is above the normal. Again, it depends on what's going on. Could you have endo? Maybe. Could you have an ovarian cyst? Yes. Could it just be that you literally sneezed too hard that day and you released more CA 125 than normal? Literally, yes. So any kind of pelvic irritation or inflammation, fibroids, polyps, in previous infection, endometriosis, any kind of inflammatory condition can increase your CA125 level. It is incredibly non-specific. So do not use your CA125 to judge what's wrong. Can it indicate that there is something wrong? Maybe, but no one, literally no one is looking at CA125 as a marker for pelvic disease, because it's so useless. Like if they're doing that, they genuinely have no idea what they're doing. I would not use that information or data. I wonder if that was that the same. PCOS was that the same person from Puerto Rico?
No, different one. No, different one.
I wonder if they're also from Puerto Rico. Maybe Puerto Rico is checking CA125 for some reason. Anyways, go ahead. Sorry, I interrupted you.
Yeah, no problem. I went on metformin for PCOS based on your recommendations.
Awesome.
What changes do patients see? Could it help me get a natural cycle back?
Yeah, there is some data which shows that metformin can increase your chances of ovulating spontaneously. It's not great data, but it's reasonable. And they don't really suggest that it's super effective for managing ovulation, but it's reasonable as far as the choice is concerned. So you definitely want to combine it with something like letrozole or Clomid, because it's very symbiotic. Together, they're better than either alone. So most of us don't treat PCOS with just metformin, but it is a reasonable start. Changes: weight loss, improved insulin sensitivity, possibly more regular cycles, less miscarriages, better sugar control if you have diabetes or pre-diabetes. In some people, less hair growth, acne, oily skin. So it can have impacts on pretty much all of the symptomatology of PCOS. I haven't looked into how much it impacts the mental health portion of PCOS. If you don't know this already, PCOS patients have a much higher incidence of mental health disorders like depression and anxiety. I'm not sure if metformin impacts that. It's just not something I've ever looked at, but I would suspect it probably does. So that might be another benefit as well.
Is there a chance of IVF funding for Windsor this year? I think there's a good chance I'll have to do another full cycle since I haven't had a successful FET yet.
It's definitely something we are hoping for. If they're going to tell us, they should be telling us kind of any day now. I know that the ministry has reviewed their program and are in the process of making changes. Whether that'll be this year or next year, we don't know. They could easily just turn around and say we were too busy, we're going to do it next year, and we got to wait. Yeah, I don't know. We're waiting. I believe me, the minute I know, we will just stop everything and do a live right after I call my wife and my mother and everybody else that's been waiting to know. But we will let you guys know that we got funding, because believe me, I want nothing more than to not have to charge people for this stuff. But one thing about the Canadian system that we all love, most of what we do, we don't have to charge anybody for. I hate charging people for this. It's nonsense. I don't want to do that. I want to be able to just treat people for free and give them the care that they need. So keep your fingers crossed. Lots of prayers. If you're religious, lots of prayers. If you're not religious, get religious and lots of prayers. So please, that's the only thing. Write to your MPs, write to the government, write to the Minister of Health, write to, Doug Ford, Christine Elliott. Like, these are the people we need to convince.
Follow up to the guaranteed IVF, it seems. So what is the criteria for qualifications?
There's a bunch of criteria. Your body mass index, previous failures, your age, the number of eggs you make, sperm DNA fragmentation, sperm quality, no comorbidities. There's some stuff that goes in there. You can't have any bad endo, that kind of thing.
In a situation where you have had 2 retrievals and multiple transfers with only 1 transfer resulting in pregnancy, followed by miscarriage, what can be done at that point for someone?
All the tests we mentioned earlier in the show. So infection testing, endo testing, immunological testing, vitamin check, check your general health, your partner's general health, look at sperm quality issues. It's not all about the ladies. It's half-half. The guys are part of the problem often as well. So if you're male and you're smoking, drinking, using drugs, your sperm is going to be terrible, even if it looks good. So all of these things can be significant factors. And we look at everything. Like, I take a very holistic approach. Thrombophilia screening can be important. Your genetic testing, his genetic testing. You're really looking at a recurrent failure or a recurrent loss situation. And we really go through that with a fine-tooth comb. Anything less than that, and you're not going to get success.
AMH of 12.28 picomoles. Is this a good AMH 36 years old? No PCOS.
Hi, Amy. It's reasonable. It's not high. It's not low. It's reasonable. It also depends on whether we did it, where our machine reads higher than most machines do. So a 12 on our machine is not as strong as seeing, for example, a 12 on a Roche, because ours is much more sensitive, so it picks up more AMH than normal. So it depends.
I am 9 weeks, 4 days, no vaginal bleeding. Ultrasound today noted small subchronic hemorrhage adjacent to the gestational sac, measuring approximately 2.2 times 0.5 centimeters. Does this increase the risk of miscarriage?
Slightly, but not enough to be worried about. And that's a very small SCH. So just take it easy. No heavy lifting, no straining, avoid intercourse. And use progesterone, and you should be fine.
Would reversing my vasectomy allow better choice of sperm for IVFs versus PISA? I'm on HCG and FSH 6 months due to TRT.
Oh, yeah, it will. I mean, ejaculated sperm is easier to use than sperm from Pisa. So yeah, there's nothing wrong with that. It's PESE, by the way, not PISA, but yeah, it's a very reasonable choice.
I recently had an initial consultation with Dr. Mayran. I really want to say big thank you to her for answering my questions with lots of patience. She is amazing, and I look forward to being your patient soon.
I love Carrie. She's awesome. So thank you for saying that. That means a lot. It'll bring a big smile to her face, and I'll let her know that you said that. So awesome. Yeah, I love Carrie. She's made of kisses and rainbows. That's what we normally say about Carrie. So she's wonderful.
Back to Puerto Rico. He also wanted to perform the laparoscopic surgery because in the HSG, They found a cyst in the right ovary measuring 2.1 centimeters by 1.2 centimeters by 1.5 centimeters. That was his other reason he gave me. Thanks so much for your opinion. Gracias.
Okay, so it depends on what kind of cyst it is. So what you're describing could easily be an egg and not a cyst. If it's filled with blood or dark material on ultrasound that looks granular and grainy, that could be endometriosis. So that's reasonable. If you're talking about so you may be talking about a saline infusion sonohystogram, which is an SIS, because on an SIS, you could see a cyst. If you actually had a hysterosalpingogram, which is an X-ray test, you can't see cysts on that. So I don't know what they told you, but you can't see the ovary on a hysterosalpingogram, even if it has a cyst. So if they did an SIS and they saw a cyst, you need to know what kind of cyst it is, because what you're describing could easily be an egg and not a cyst at all.
What are some things to consider in aftercare of someone who had an ectopic pregnancy?
Follow the betas down to 0, ideally. Make sure they're recovering well. And then just guide them on, appropriate precautions when they try again, depending on what their tubes look like. Some of us will do testing for them before they try to make sure the other tube is still functional, or the one that had surgery is still functional, or even if it was methotrexate, that it's still functional. So all of those things can be important. Some people won't, but you need close follow-up in your next pregnancy, serial beta HCG, ectopic precautions, someone with you at all times, that kind of thing.
906. Last
906.
question.
Yeah, sure. Are there like a million? Because I can't see them all.
No, we're winding them down.
Okay, fire away.
Okay. Just had my first transfer and it failed. What are some causes of implantation failure? Does having one unsuccessful transfer increase the chances of a second unsuccessful transfer?
No, one doesn't. Some, if you have more than one, it can. But one alone will not be a major issue. So if you only have had one failed transfer, IVF doesn't always work. As proud as we are of our success rates, even for us, it doesn't always work on first try. Are we, getting very high success rates? Yes. Are we getting to the point where someday we can get, very, very, very high success rates? Yes. But does it work every time? No. I'm going to present a topic next week on what the impact of the morphology of your embryo and your age is, even if your embryo is genetically normal. So this is a super huge topic. I'm going to promote the show because I'm really hoping a lot of people attend that. Bottom line is there is an impact. So even if you're making genetically normal embryos, your age and the quality of the embryo still have a factor in determining whether or not you're going to be successful. Do you want me to take that last question?
Yeah, I'm pulling it up right now.
I had 3 IUIs, April, July, and August, all unsuccessful. I'm sorry. Use Gonal-F, Menopur, Orgalutran, etc. for the IUIs. Surgery in September with Dr. Toms, great friend of mine. Found endo, which he cauterized. Just had a 4th IUI, January 25th. Okay, my chances tomorrow. Are my chances higher to be pregnant this time around? Is there a wait list for IVF? There's no wait list for IVF if you're paying privately. Your chances of getting pregnant this time after your endo was operated on is almost double what it was before that. So yes, you have a better chance. Okay, guys, Tarek has given me the secret signal here to wind up the show. So thank you for watching these weekly shows. Thank you, Amy. We appreciate that. And thank you for asking your questions, guys, and participating. Let us know if you think there's something we can do on the show to make it better. And jump on that YouTube channel, hit subscribe. If you have friends, let them know about us and get them to join on Instagram, Facebook, YouTube. And we will see you again next week, where we have a super important topic, which is, as I mentioned, about embryo morphology and your age and its impact on success, even when the embryo is genetically normal. because having a genetically normal embryo is not all it takes. Have a great night, and we will see you again next week on Fertility Factor Fiction.
Tuesday. Mention Tuesday.
Yeah, Tuesday. Is it Tuesday? Oh yeah, because next Monday is Valentine's Day, guys, and we think there's more reproductively positive stuff to do on Valentine's Day than watch me. So let's see. Oh, hey, Dr. Victory, I'm listening from St. Vincent in the Caribbean. Just want to say I do enjoy all of your sessions. They're very informative. I think that's awesome. And for what it's worth, I'm coming out to the Caribbean in March, but for holidays. So we will hopefully enjoy your beautiful part of the world. Have a great night, guys. Thank you for watching from all over the world and for making this show international. And thank you, as always, to the amazing Tariq Ibrahim from Ibrahim Strategies Group, who has put together all of this for you guys. Have a good night. We'll see you again next Tuesday on Fertility Factor 50.